A very good evening to everybody, and it's a pleasure for discussing with all of you this very important topic today with regards to the perinatal endocrinology, which is a very important issue, one which is often not given enough importance because of various issues, but we thought we'll discuss about the entirety of perinatal endocrinology and how it helps in terms of evaluation and management of various endocrine disorders, because this is one period which basically has a significant change in terms of the endocrine milieu of the individual, which happens during this phase, and we need to understand a lot before doing a comprehensive evaluation in terms of pediatric endocrinology, particularly from the neonatal perspective. So we will now start the talk, and what we're going to do today is basically we'll be starting off with a brief introduction about the topic. We'll talk about fetal endocrinology because that is one phase in which significant changes happens in the fetus perspective. We'll talk about the role of placenta in endocrinology. We'll talk about then the perinatal changes and how we can really understand the grips of various disorders using those physiological approaches. And then we'll discuss about the launch of the neonatal endocrinology course as part of the MedEClasses initiative. So as many of you will be aware, that we have the MedEClasses online portal on pediatric endocrinology, which has been providing information about wide variety of pediatric endocrine disorders. You can go and visit our Learning.Grow Society website. You can scan this QR code to go to that site, and there are a lot of options available in terms of the courses. And today marks a very important part because we are going to talk about a neglected area of endocrinology, and we're going to really have a new entire course dedicated to neonatal endocrinology with over 14 modules. We'll discuss that a bit later on in this perspective. So you can access all of this along with variety of resources on learning.growsociety.com, and you're free to share your feedback on the email. We have a chat option available with this, so you can really use that option as well. So perinatal endocrinology is a very interesting area, one area in which there are significant changes happening in the overall dynamic milieu as far as hormones are concerned, and these have implications in terms of assessment and management of endocrine disorders. So perinatal period is a period in which a fetus, which is completely dependent on the mother, is basically trying to build up the structure to face the bird once it comes out of it. So it's in an anabolic phase with very limited metabolism. And we have a placenta which provides free access to glucose, calcium, and temperature, and therefore it helps the fetus to really grow. The only work the fetus does is to grow, and it is entirely dependent on the placenta. But as soon as the delivery happens, the child is born, there are dramatic changes which happen from a dependent to an independent state, which requires shift of metabolism from anabolism to catabolism and from incipient stage to active stage. And all of this is largely regulated by hormones. And therefore, these changes in hormones are so dynamic that we need to really understand them when we are assessing and managing these disorders in terms of pediatric endocrinology. So we'll start off with the fetal period, and we have already discussed that this is a phase in which the child is entirely, the fetus is entirely dependent on the mother through the placenta regarding various nutrients. So we'll go one by one the various endocrine systems, how do they mature and how do they adapt to fetal environment. So the most important part, of course, is the hypothalamus and pituitary. The hypothalamus typically has its origin around 4 to 5 weeks, but 6 weeks there is a reasonable development of hypothalamus. And the pituitary development typically lags by around 3 to 4 weeks. So by 10 weeks, we have the hypothalamus and pituitary, which is developed, but the different hormonal axes mature at different phases. So the growth hormone axis in the form of a GHRH, growth hormone, and IGF1 axis will mature somewhere around 12 weeks of life. However, the growth hormone levels are on the lower side in this phase. By around 8 weeks, we have the development of the TRH, which acts on the TSH, resulting in development of thyroid, and T4, which is actually secreted by around 16 weeks of gestation. The feedback mechanism takes a bit longer, maybe around 18 to 20 weeks, which is there. We have the dopamine prolactin axis, which is basically inhibiting prolactin secretion in this age group. We have the CRH, ACTH and the adrenal axis, which is largely quiescent. At this stage, cortisol is produced for some time around 8 weeks of gestation, and we'll discuss how it is extremely important so as to avoid the androgenic effects on the female fetus, but otherwise it doesn't have any significant role in the antenatal period. The feedback inhibition typically matures by around 10 to 12 weeks of life, as highlighted by the findings in congenital adrenal hyperplasia, where cortisol deficiency result in high levels of ACTH. And we have the gonadotropin axis, which is gender dimorphic. So we have the LH and FSH, which start to be produced around 12 weeks, peaking around the mid-gestation, and the testicular axis, which is hugely active, particularly from the endocrine perspective, while the estrogen axis is quiescent, and we have the first production of estrogen, which happens somewhere around the term gestation. So within this paraphernalia, which looks a bit complicated, but we'll deal all of them individually and see how they change in the situation. So we'll start off with the growth hormone axis, and all of us know that growth hormone plays a very limited role in terms of fetal growth regulation, and that is because the GRH levels, the GH levels are low, and there seems to be a growth hormone resistance state. However, IGF-1 plays a very important role, and it is the major regulator of fetal growth. So therefore, individuals who have growth hormone deficiency are therefore normal sized at birth, while IGF-1 deficiency or IGF-1 insensitivity are associated with significant growth failure. Very importantly, insulin has a structural homology with the IGF-1 receptor and acts with around 5% relative potency as IGF-1, and it therefore is associated with increased growth. So insulin excess states, particularly in diabetic mother, will present with macrosomia, while insulin deficient states like neonatal diabetes, which we'll be covering a lot in the module, are associated with intrauterine growth restriction. So therefore, we can summarize that there is no role of growth hormone in regulation of fetal growth. IGF-1 is a main player, and there is a definite role of insulin in this perspective. What about the most important, hypothalamic-pituitary-thyroid axis? And what we see out here is that TRH, of course, is there since quite beginning, and TRH is one hormone which is very easily transferred through the placenta and also produced by the placenta. So TRH, even before the hypothalamus is producing, fetus will have reasonable amount of TRH to begin with. This then acts on the TRH receptor to produce TSH, which acts on the TSH receptor to produce T4, which essentially is a prohormone. This T4 can be activated using the monodeiodinase type 1 enzyme to T3 and inactivated to reverse T3 by the enzyme MDI3. And it is really the balance between MDI1 and MDI3 which determines the fate. So in situations where the body wants less thyroid, like in the fetal life, the MDI3 will be more active, while when we require more of thyroid hormones, that is immediately after birth, MDI1 takes up the picture. So basically, the regulation is at the level of activation or inactivation of T4. Then of course, T4 and T3 are bound to the thyroxine binding globulin, and the free hormone is transported using the MCT8 transporter and acts on the thyroid receptor to produce action. Maturation and the formation of thyroid happens by around 7 weeks of life, while TRH by the hypothalamus is produced around 8 to 9 weeks, and TSH starts around 14 to 15 weeks. So what this tells us is that the thyroid development is independent of the hypothalamic-pituitary axis, and only if there is TSH deficiency, we will have thyroid which is formed, but it will be on the smaller side in this situation. At around 10 weeks, we have the thyroid hormone which comes into the picture. What it tells us is that the thyroid hormone levels are quite low in the initial phase when the maximum brain growth is happening, because the fetal production is less. But as we will discuss later on, there is a transfer from the mother to the fetus in terms of thyroid hormone, and that plays an important role in sustaining neural development in this situation. At around 18 weeks, we have the full HPT axis which is formed. So a word about fetal thyroid metabolism. So we already discussed that fetus wants to avoid thermogenesis because its temperature is already taken care of by the placenta. It wants to conserve that energy and gain weight. So it is in an anabolic state and wants to preserve the brain function. How is this happening? This is mainly happening through the interplay between the monodeiodinase enzymes. So in the fetal state, the monodeiodinase type 3 is hyperactive, resulting in increased level of inactive form of thyroid, while MDI1 is inactive, resulting in low level of T3, which is further sulfated into the inactive form. So we basically have a situation wherein there is low level of systemic T3. But what about the brain? Brain definitely needs a thyroid hormone. So for that, we have the local monodeiodinase type 2, which is located in the brain, which provides enough T3 to the brain. So basically, fetus lives in a state where the systemic levels of T3 are low, but brain levels are normal. So the amount of thyroid hormone required for brain development in the fetus is therefore limited, implying that in situations like fetal athyrosis, maternal transfer of T4 will be able to sustain the mental development because we need very little thyroid hormone to really achieve the outcome in this perspective. So fetal thyroid metabolism is characterized by a state in which there is more reverse T3 and less T3. So it is a balance is shifted towards inactivation. Now this is extremely important side to understand because it has implications in terms of assessment in the preterm babies. So what we see out here is that the different thyroid hormone levels change over the period of gestation. So basically what we are seeing is that T3 levels tend to remain low throughout pregnancy, only to rise from around 28 weeks, and then at birth there is a sudden rise which is happening, which is basically causing the thyroid surge. This is about T4, which starts to rise a bit earlier, around 20 weeks of gestation, and by around term the levels are reasonably high, but then they again have a big surge. So what it means is that if we are dealing with a situation wherein we have a gestational age of around 24 to 28 weeks, in that phase we are having a situation in which the thyroid hormones will anyway be low. So in this situation, if we do a thyroid function in a premature neonate around 28 to 30 weeks of gestation, the thyroid hormones will be low, but this transient hypothyroxemia of prematurity is more of a physiological state. And it may actually be saving the neonates because studies have clearly evaluated that routine supplementation of thyroid hormone during this time actually worsens the outcome rather than improvement. So if the TSH level is normal and T4 is slightly low in admitted NICU setting, then better would be to wait and watch rather than start treatment. What about TSH? What we see, the TSH starts rising from 16 weeks and then it keeps on increasing till term where it is around 7 to 10, and then there is a sudden surge and which goes down, and we'll talk about the postnatal changes later on. The major implications as discussed of this graph is that in the antenatal period, in that situation, we don't need to be bothered about mildly low level of thyroid hormone in this setting because that may be a physiological response. So now we have a 10-year-old boy whose period of gestation is 29 weeks. He is on phototherapy, ventilation, everything is normal. Somebody thought we'll do a thyroid profile. And what we see is that thyroid is 6, which is on the lower side, which is 6 picomoles per liter, and TSH levels are normal. So what do you think is going wrong? You can use the chat option to really mention whether you think you would like to treat this child who is born at a gestation of 29 weeks, has a low FT4 and a normal TSH level. So how many of you would like to start treatment in this situation? We can use the chat option to assess. So this is clearly a situation which is a transient hypothyroxemia of prematurity, and there is no need to start treatment, and treatment may actually be detrimental in this perspective. So once we have discussed about, so we agree with Dr. Sunita and Dr. Bansal that we don't need to give any treatment in this situation. So now we'll talk about the next very important axis, which is the hypothalamic-pituitary-gonadal axis, because this is the time when a lot of internal development is happening, a lot of external sexual development is happening, and all these factors are regulated by the HPG axis. So in this situation, we have the hypothalamus-pituitary and the gonads. The hypothalamus secretes GnRH, which stimulates the gonadotrophins and which result in production of estradiol and testosterone. And we'll discuss about how these things change over the period of gestation. So at 8 weeks, we have the GnRH, which is produced. At 18 weeks, we have the gonadotrophins, which come up, and estradiol is only produced at 40 weeks. Very importantly, at 11 weeks, we have is the voice clear? I think we had a message from Dr. Bansal that there is no voice. Is the voice clear? Okay, fine. So we'll continue with that. So basically, very importantly, testosterone production is in the initial phase is regulated by the HCG, which is produced by the placenta. And this HCG in the first trimester controls testosterone secretion. One will wonder, why are we so bothered about that? It is extremely important, as we have discussed, that the LH, FSH are coming only at 18 weeks. But boys to virilize will require testosterone from 8 weeks of gestation. So if there is no testosterone production, then we won't expect any sexual development. So it is the placental HCG which takes care of the testosterone production in the first trimester. And this has very important implications in terms of manifestations of hypogonadotropic hypogonadism. So individuals like with Kalaman syndrome or other forms of congenital GnRH deficiency have normal testosterone production during 8 to 12 weeks of life because of the placental HCG. And what we know very clearly, as we'll discuss, is that this phase is very crucial. If you have androgen deficiency during this phase, we will have disorders of sexual development, while androgen deficiency beyond this age group will only cause micropenis, but not DSD. So therefore, individuals who have hypogonadotropic hypogonadism present only with micropenis, but not disorder of sexual differentiation. And this is because of the HCG effect in regulating testosterone, and this we'll discuss later on, and we'll talk about DSD a bit. So very importantly, the GnRH is actually, GnRH neurons are formed in the olfactory placode. From there, they migrate into the hypothalamus, and they also have simultaneous migration to the olfactory lobe. So conditions which are associated with abnormal migration will typically present with abnormalities in the hypothalamic GnRH, causing hypogonadotropic hypogonadism and anosmia. And this is something, the first question you will ask with a boy who comes to you with delayed puberty is whether they can smell or not. And if there is lack of smell sensation, it will indicate directly towards a hypogonadotropic hypogonadism because of Kalaman syndrome. And this is the embryological basis of this abnormality. Now, very importantly, we already discussed as to how the changes are happening, and this has implications. So what we see basically is that the FSH level tend to rise before birth. So on the left hand side, we have the antenatal age, and on the right hand side, we have the postnatal age. So what you can see that FSH levels tends to start rising from around 12 weeks, peak around 26, 28 weeks, and they even reach the menopausal level. Similarly, for LH, we have a peak which is happening around 20 to 24 weeks. What it means is that if you have a premature female neonate and you are doing LH-FSH because of whatever reason, of course, if there is a suspected DSD or there is a clitoromegaly, which is often misdiagnosed as DSD in this group because it is more because of labial edema. In that situation, the LH and FSH levels will be very high. So high LH and FSH level in a premature female are not suggestive of pathology, but they are part of physiology. So we discussed that thyroid hormones may be low, LH, FSH may be high in preterm neonates, and that's the big message which is coming out from this slide. Very importantly, estrogen production usually doesn't happen before the birth, and postnatal changes we can also see that there is, after birth the levels go down, and there is a second surge which happens, which is known as mini puberty, which we'll discuss a bit later on. So now we have a 3-day-old girl, preterm, period of gestation 29 weeks, has clitoromegaly, there is no labioscrotal fusion, and this is a common presentation. Preterm infant presenting with what looks like a large clitoris, but there is no labioscrotal fusion. There are no palpable gonads, so it goes against the possibility of a XY DSD. So now somebody did a LH-FSH level, and they found that the LH and FSH are 24 and 32, and they are really alarmed, and they are now asking you for consultation whether this child has a form of a gonadal failure maybe, which is causing this problem. So what do you think? Are these LH-FSH levels in a 29-week-old gestation 3-day-old girl significant in this situation? How many of you would like to work up further, maybe do a karyotype or some other workup for DSD? You can use the chat option in this perspective. So clitoromegaly, no gonads, high LH, high FSH levels in a premature infant. How significant? Is it significant? Yes or no? I think you can use the chat option so that we can have more interaction on that. Yes, so now we really get that this is more of a physiological. Dr. Pragya has really answered it correctly. So this is what we discussed, that this is a surge which is happening in terms of the LH and FSH level, and there is no need for any intervention at this point. In fact, don't get LH-FSH level. One clinical pearl out here is that this clitoromegaly is not really clitoromegaly. It is the edema around the clitoral tissue, which is common in prematurity. If you try to really measure the length of clitoris, it will not be increased, and there would be no erectile tissue in the clitoris. So that will really indicate that nothing is to be done. Don't do these hormone reports, otherwise they will confuse you. Just follow up, and this will improve over time. This is prematurity related. What about boys? Unlike girls, as we discussed, the HPG axis is very active in boys. What we are seeing is that as boys usually have a LH predominant response, their LH levels are high, and typically similar phenomena. At around 22 weeks, the levels are high, and then they come down, and then they really go up at that time. So what this tells us is that if you are evaluating a boy for a testicular function, you can either do at birth, because at that time the levels will be high, but after 24 hours the levels will really be low, and then they tend to rise with mini puberty. So if you have a DSD in an XY DSD, you want to do a hormone levels, you do at day 1 or beyond 1 month of life typically. If you're doing in between, you need to stimulate it using a HCG stimulation test, which we discuss in the puberty module and when we discuss the pubertal physiology part of it. What about testosterone? Very importantly, unlike estrogen, which is rising from 36 weeks, we see that testosterone is actually rising much earlier, and this part is largely because of HCG. And this, we discussed, is responsible for lack of DSD in a child who has hypogonadotropic hypogonadism. So now coming on to the very important part of gonadal development, we all know that gonads are formed from the urogenital ridge, and this ridge gives birth to 3 major organs. We have development of this ridge by 4 to 6 weeks, from which we have the adrenal, and the major regulator there is the gene NRA51 around 6 to 7 weeks. We have kidneys, which are formed using mainly the WT1, the Wilms tumor gene. And finally, we have the development of the bipotential gonad, for which the major regulators are again both these genes which play an important role. So individuals who have NRA51 mutation have an adrenal insufficiency and DSD, while those who have WT1 problem have a kidney problem and DSD in this perspective. Following which, in the presence of SRY, we have development of testis, and this requires collaboration with NRA51 and a very important protestis gene, which is SOX9, and from testis we have the production of anti-mullerin hormone, which causes the regression of the mullerin hormone. In the absence of SRY and the presence of anti-testis genes like FOXL2 and DAX1, we have the development of ovaries, and there is a fight between genes which really decide whether we're going towards testis or ovary. So the major development of testis is determined by SRY, but there are other factors which also play an important role in this perspective. What about germ cells? Very important to remember that germ cells have nothing to do with gonads. They develop from the coelomic epithelium. So we have the hind gut, from which around 6 weeks of gestation we have the germ cells which start and they migrate to the ovaries, and where they are really stopped at a mitotic state at around 10 to 11 weeks, and similarly they migrate to testis where also they are stopped to grow further. Some germ cells can migrate into the non-gonadal areas where they are usually apoptosed, but some may persist, and these germ cells cause the ectopic HCG producing tumor, which cause peripheral precocious puberty in boys. So this is important to understand that your testicular production or the ovarian hormone production has nothing to do with germ cells, because these are entirely different systems which in terms of their development and embryology. What about testis? So testis basically under the influence of various genes develops. So we have the Sertoli cells which develops under the SOX9. It produces anti-Mullerian hormone which causes regression of the Mullerian structure. Inhibin B, which is also an important feedback inhibitor, and Leydig cells under the control of NRF51, which control also the adrenal, and this produces testosterone and insulin-like factor 3. This insulin-like factor 3 is the major determinant of testicular descent. So the abdominal phase of testicular descent is controlled by insulin-like factor 3, while the inguinoscrotal descent is controlled by androgens. So knowing this is very important. If you have a DSD whose testes are there in the inguinal region, you know that there is some production of insulin-like factor 3. Somebody whose testes are in the abdomen would mean that they have no production of the Leydig cells. So this is a very good way to think of what could be the defect based upon the situation. You also have the germ cells. As far as ovarian development is considered, we have the various genes which result in the development of Zika cells which produce androstenedione, which is converted by the granulosa cell to produce estrogen, and we have oocytes which produce AMH in this situation. Now, once we have the gonadal development, the next step is the internal structure development, which is gender unimorphic across both genders. At 7 weeks of gestation, we have the AMH, which basically takes off the Mullerian structure, and around 8 weeks, we have testosterone, which acts on the Wolffian duct to produce epididymis, vas deferens, and seminal vesicle. So this is how from a gender unimorphic we become a male development in this perspective. Female development, in the absence of testosterone, and the presence of testosterone, the Wolffian structures go, and the Mullerian duct develops into fallopian tube, uterus, and upper third of vagina. This is important implication. So vagina has a double area of the development. The lower part is developed mainly by the urogenital sinus. The upper part is developed from the Mullerian structures. So in those who have Mullerian agenesis, there would be a blind vagina, but there will be some vagina which is there in terms of development. External genitalia development happens mainly under the influence of dihydrotestosterone, and we have the male development with a very important window, as we discussed, between 8 to 13 weeks of gestation, wherein HCG takes care of the testosterone production, and we have the estradiol, which results in the female development. And very importantly, if there is androgen exposure till 12 weeks, there will be labioscrotal fusion, but after that, usually there will be clitoromegaly and no labioscrotal fusion. So now we have talked about the growth hormone, we have talked about the thyroid, we have talked about the gonads. Now we'll talk about adrenal axis. And if somebody asks me which is the most important axis in the neonate or the child, I would say it's the hypothalamic-pituitary-adrenal axis. But if somebody asks me what is the least important axis in the antenatal period, I would say it is the HPA axis, because all the functions of the adrenals are taken care of by the placenta, and we'll discuss that. So this involves the CRH, which is basically regulating the CRH receptor to ACTH, which acts on its own receptor to produce cortisol, and this cortisol has only one role in the antenatal period. This cortisol at 8 weeks of gestation causes suppression of the ACTH secretion, which avoids the development of virilization in girls. Otherwise, the fetus is independent of cortisol, no role of aldosterone at all, no role of DHEA. So adrenals as such are not doing anything in the antenatal period. So 7 weeks we have this formation, cortisol comes around 8 weeks, again we have this excess. But is it that the whole adrenal are useless? No. Adrenals are very, very active in the antenatal period. They're not doing for themselves, they are doing for the mother. So we have a large zone of fetal zone in the adrenal, which has got very low level of 3-beta-HSD. Now, if you remember the pathway, what it means is that there will be no production of cortisol and aldosterone. Everything will be shifted towards DHEA, and which will be converted because of high 17-hydroxylase lyase and sulfonyl-transferase into DHEAS. And this DHEAS is aromatized into estriol. So very high level of estrogen in mother are partially explained by the fetal adrenal, which is producing this DHEAS. So in other words, fetus is acting like a factory to provide the raw material of DHEAS for the mother. At 10 to 12 weeks, there is some cortisol production, which inhibits the androgenization as we discussed. Aldosterone has limited role and DHEAS is not required. Very importantly, placenta has got a 11-beta-HSD2, which inactivates cortisol and prednisolone, and it has no effect on dexamethasone. So what it tells us is that if you want to treat the mother and not the fetus, use hydrocortisone or prednisolone. But if you want to treat the fetus, like the antenatal maturity for lungs, or you're talking about a cardiac block in the setting of SLE, use dexamethasone. So we have a 26-year-old lady with rheumatoid arthritis on prednisolone. She is now pregnant. What do we do? So how many of you would like to stop this prednisolone in this situation? So you can write your options using yes or no on the chat option. So she is on prednisolone, well controlled. Do we need to stop because parents are really concerned that this child is going to be affected if we give steroids in this perspective. So do we need to continue or discontinue is the question. Yes, Dr. Palani, and what we see here is that this prednisolone will not cross the placenta. So we can safely continue the same. We now have Dr. Bansal, I think from our side the voice seems to be fine. Anybody else has a problem in the voice as well? We will have the whole recording of the this whole part, which will be available on the YouTube as well as the website. So if there are some problems, we can really discuss that in detail on that. So now we have the second case, 28-year-old lady with SLE, pregnancy, 20 weeks of gestation, fetal heart block, and the child is positive. She is positive for the anti-Rho and anti-La antibodies. Now the question is, you want to treat the fetus. So which preparation will you use? So we have option whether you can use hydrocortisone, prednisolone, or dexamethasone. So you can just tell me whether you will use dexa, hydrocort, or prednisolone. So we have a child who has a heart block, and you want to treat basically the child and not the mother. And definitely, Dr. Palani, we need to treat with dexamethasone in this situation, which is definitely beneficial in this perspective. So now we will come on to the two most important aspects of fetal physiology, calcium and glucose. And these are very important because they have significant implications for the neonatologist and the pediatrician. And that's why we have kept this towards the end to make it more interesting in the fetal physiology part. So we all know that calcium in the fetus is directly transported from the mother using active transporters, and maximum transfer happens in the third trimester by around 80%. This is largely regulated by the parathyroid hormone related peptide and not pH, and this ensures a gradient of 1.4:1 between mother and fetus. And if we have a premature baby, they will be missing the maximum deposition in the third trimester, which is somewhere around 100 to 130 milligram per kg per day. So of course they will have low bone mass, they will have a high risk of hypocalcemia in the setting of prematurity. And this whole calcium basically comes from the mother because it is driven from PTH-related peptide and calcitriol during pregnancy. Having said that, although the fetus is dependent on the calcium from the mother, it itself has a PTH axis which is working. So if you have maternal hypercalcemia, you will have high fetal calcium and a PTH level will be low. So what do you expect in that situation to happen in the newborn period? So I'll repeat the question. If there is maternal hypercalcemia in the fetal period, what would be the neonatal calcium level, high or low? This is a very logical way to look at it. You can think of an infant of diabetic mother. You have a hyperglycemic mother, hyperglycemic fetus, insulin levels are high. At birth, suddenly there will be a crash in hypoglycemia. So hypercalcemic mother, hypercalcemic fetus, low PTH, after delivery you will have hypocalcemia. On the opposite, if mother has persistent vitamin D deficiency and hypocalcemia, fetus will be hypocalcemic, PTH will be high, after birth you will have hypercalcemia. So therefore this is a very interesting thing which is applicable both for calcium and glucose, and I think this is a very interesting thought I thought we can discuss on this aspect. What about glucose physiology? Fetus is entirely dependent on the mother for glucose. 80% of its energy needs are given from glucose. There is no endogenous production, and this transfer, unlike calcium, happens using a passive transfer using GLUT1 and GLUT3, and therefore the levels in the fetus are around 80%, while for calcium it was 140% compared to the mother. Now we all know that insulin cannot cross the placenta, and this is very important, otherwise hyperinsulinism would have caused basically a hypoglycemia in the fetal period. And insulin receptor causes glucose. In pregnancy, the fetus wants more glucose. So it produces a HPL, which is human placental lactogen, to cause insulin resistance in the mother, to cause hyperglycemia, so that the fetus gets more glucose. So in a way, fetus is causing a harm to the mother, and that's why we have all the diabetes which is happening, the gestational diabetes, insulin resistance which happens during pregnancy, to ensure that it has enough glucose. It's a very interesting thing to think of. So basically what happens is that there is more glucose in the fetus, and this glucose will then trigger insulin and it will inhibit glucagon. And it is the increase in insulin to glucagon ratio which triggers fetal growth. And this, along with that, we have a glycogen deposition, and again maximum happens in the third trimester. So if you have a premature infant, you will have low glycogen, risk of transitional hypoglycemia which will happen in this situation. So now we have talked a lot about fetal endocrinology. The next issue is what about placenta? And often placenta is considered as an inactive organ of limited consequence, but actually placenta plays an important role. It can allow certain substances to cross, like TRH we discussed, it can cross. T4 can cross, and this T4 is enough to sustain mental development in a athyrotic fetus. So it's very important. So if mother is hypothyroid and untreated in the first trimester, fetus may have adverse effects in terms of intellectual outcome. This we have to understand. TSH receptor antibodies, whether they are stimulating or inhibitory, they cross the placenta and they will cause thyrotoxicosis if they are stimulatory and hypothyroidism if they are inhibitory. This will be a transient phenomenon. Calcium we discussed crosses, glucose we discussed also crosses in a passive fashion. But placenta also acts as a sieve. It doesn't allow TSH to cross, we discussed it doesn't allow insulin to cross, it doesn't allow hydrocot to cross. Very importantly, it doesn't allow androgens or estrogen to cross because there is a 17 beta gestation. Otherwise, there will be a feminization of the male fetus and virilization of the female fetus. So this is a very important role of placenta in regulating what can go through its check post and what cannot. Very importantly, it also allows the transfer of DHEAS after aromatization to cause the development of estrogen. If there is no aromatase, we will actually have maternal virilization. So this is one rare condition in which fetus is driving mother's virilization. And that brings us to this very interesting case. 3-day-old child with disorder of sexual development was born with DSD, no palpable gonads, XX karyotype, slightly high 17-OHP, diagnosed as CAH, was started on hydrocortisone. The doses were reduced, but even without hydrocort, the levels were normal. So when the child actually came to us, she was off steroids, had normal 17-OHP, and presented mainly with delayed puberty at 14 years of age. So now we have a girl who had disorder of sexual differentiation, hyperandrogenism at birth, and now we have estrogen deficiency. So what could be the possible cause? And one question which you should always ask, we talked about anosmia in Kalman, DSD, always ask whether mother had a virilization during pregnancy. And this case, there was a delayed puberty in the girl and mother had a virilization, and that really gave us a diagnosis of aromatase deficiency in this situation. So aromatase deficiency should be suspected in a girl who is XX DSD with maternal virilization, and they will present with delayed puberty subsequently. They may be misdiagnosed as congenital adrenal hyperplasia because that's the most common cause of the DSD in most situations, but we need to be wary about this. Now, placenta can also act as an endocrine organ. It produces HCG, which, as discussed, plays a very important role in testosterone production in males. But what does it do to females? In the mother, in the sense, and it also produces estrogen. So this HCG can cause increased T4 production because it has a structural homology with TSH. So in pregnancy, we have a relative thyrotoxic state, while high estrogen will cause a further increase in total T4 because there is a more thyroxine binding globulin, but the free T4 will be normal. So in pregnancy, the TSH point typically comes down by 1, and that is why we use a cutoff of 4 because of this HCG effect in the mother. We also know that we have HPL production, which causes insulin resistance and gives more glucose to the child in this perspective, as we discussed earlier. So we have discussed the fetal changes, we have discussed the placental role, and now we'll come back to what happens at birth. So birth is a very important phase in which all the endocrine organs seen, and this is a simple slide in which we are trying to depict everything. So at birth, you see a high growth hormone level because of the lack of inhibition. And along with that, there is no change in IGF-1 because there is growth hormone resistance. We all know that birth is associated with TRH surge causing high TSH and high T4. Prolactin levels increase because there is a lack of inhibitory effect of dopamine. There is a decrease of cortisol. There is initial decrease in LH and FSH, followed by an increase resulting in what is known as bilirubin. So if you go one by one, as far as the growth hormone axis is concerned, somatostatin comes down, growth hormone goes up, but because of growth hormone resistance, IGF-1 production is not affected. There is reduced inhibition. Growth hormone levels may grow up really high. So if you do a growth hormone and you find it to be high, don't bother. It is a normal neonatal response. And this is because there is growth hormone resistance, and this resistance comes down only after 3 to 6 months of life. And therefore, growth hormone plays a very limited role in growth in this phase. What about thyroid? And this is very important from pediatrician perspective. Now we need temperature to increase, we need a catabolic state, and therefore the MDI3 goes down, RT3 goes down, MDI1 goes up, T3 level goes up, and sulfation goes down. So there is a shift from a hypoactive to a hyperactive thyroid, mainly because of a changes in the MDI. So therefore, this postnatal phase is associated with high T3 and low RT3 with predominance of the activation pathway. And this is reflected in this graph, which beautifully shows how T4 and levels go up and TSH levels also go up. Very important to remember that this thyroid surge is blunted in premature infants. So in prematurity, there is a chance of having a falsely negative thyroid screening. And that can have implications in the sense that we need to do a repeat thyroid screening in these infants subsequently at around 3 to 4 weeks of life. This is extremely important in those who are hospitalized and those who are also receiving vasopressors like dopamine. What about the hypothalamic-pituitary axis? Very important to evaluate, particularly for DSD perspective. So there is an initial decrease in hormones, but then there is a mini puberty which kicks in and the levels go up, and there will be high levels of testosterone and estrogen. This is what we discussed. So there is a fetal rise, we discussed the gonadotrophin, and then there is again a mini puberty which needs to be considered in the evaluation in this age group. What about adrenals? And we said that adrenals are useless for the fetus. They are important for the mother, but in the postnatal period, they are extremely important. So after delivery, we have changes in the form of ACTH, which causes more cortisol. There is again change in the steroidogenic pathway, so aldosterone becomes more, and this plays an important role. However, there are remaining effect of high sulfation, and therefore a lot of these products are there, and cortisol levels are very high in the fetus. So therefore, cortisol level assessed by enzyme immunoassays are not reliable. If you really want to look at the exact level of cortisol in the newborn period, do an extraction assay or use a gas chromatography and mass spectroscopy. Now, many labs are doing GCMS, but we need to be wary about that you have to write that you want GCMS and not an enzyme-linked assay, because they may be unreliable in this period. So we have a 3-day-old neonate born to a mother with hypopituitarism, has micropenis, has hyponatremia, and the 8 AM cortisol is normal. So you are really bothered about whether this is normal or abnormal. So now the first question which you will think of is whether this is done by a GCMS assay or an enzyme immunoassay. And what you're seeing is that this was done using GCMS, repeat levels were low. So therefore we have to be careful in interpreting the normal reports. So most labs will do an enzyme immunoassay. So you have to be careful if you're looking in the newborn period. This is what the big message out here is in this perspective. So adrenals have a huge change in the fetus. There is a large fetal zone, a small definitive zone, mainly producing DHEAS. In childhood, we have decreased fetal zone, zona glomerulosa and fasciculata come in. Main hormone which is produced is actually cortisol. And finally, in puberty, we have the reticularis zone which comes in, which produces DHEAS. So all you need to understand is that in the first 1 month, assessment of the adrenal axis is difficult. Aldosterone plays an important role, but not in the first 2 weeks of life, because there are tubular problems which are there. In that phase, salt wasting is unlikely. So salt wasting crisis typically happens beyond 2 weeks of life. You may have hyponatremia, that is because of free water excretion, but not because of salt wasting in this situation. What about calcium? As soon as the placental supply goes off, calcium goes down. We have increased PTH, decreased calcitonin, and calcitriol has a minimal role. It has a partial role, but that results in normalization of calcium. But every child will have a dip in calcium. So calcium, we said, was 1.4:1, so it was high. This is ionic calcium, so it was pretty high. 6 is high. And then it is coming down, lowest levels by 24 hours. So if you have prematurity, if you are small for gestational age, if there is birth asphyxia, this dip may be exaggerated. What is known as early onset hypocalcemia. And this is very important, as you see, for prematurity, the dip is much more and sustained for a larger period. What about glucose metabolism? And what we see in glucose metabolism is that as soon as the placental supply goes off, the glucose levels come down. We have secretion of epinephrine, which basically controls this along with decrease in insulin, and some glucagon response which maintains the glucose level mainly by glycogenolysis, gluconeogenesis, and partially by lipolysis. Very importantly, ketone formation does not happen in a proper fashion in the first 24 hours of life, and therefore all hypoglycemia in the first 24 hours of life will be hypoketotic. All these adaptations are usually complete by 48 hours. So any changes in glucose levels beyond 48 hours are considered to be significant because they may be indicative of a pathological cause. So if you look at the neonatal sugar levels, you find that the levels are lowest at around 2 hours, and then by 48 hours they pretty much come to the adult range, and the levels will be lower in the premature infant. And this is implication. Within 48 hours, don't bother, but if it is persistent hypoglycemia beyond 48 hours, you have to be really worried about the situation. The 12-hour-old girl with jitteriness, blood sugar is 24, ketone is negative, no organomegaly. What do you do? So how many of you think that this is a non-ketotic hypoglycemia? Think of hyperinsulinism. So is this hyperinsulinism? Yes or no? You can again put through the chat option. A child who is